Good morning, everyone. I want to tell you a story today about a trip that I got the chance to go on last winter. I went to Guatemala with my mentor here at OSU and a group of our undergraduate students. We spent the next couple of weeks in Guatemala, traveling around and visiting different tuberculosis hospitals, clinics, and orphanages. This is a picture that was taken at one of the hospitals that we visited. And this is a picture of their drug-resistant tuberculosis unit. These guys have been diagnosed with drug-resistant tuberculosis. And they're sitting inside of this unit, separated from the rest of the patients in the hospital by this open barred door. So these guys were sitting around the table playing a game of cards with their mask on. And we were outside of the unit talking with one of the doctors as a group. And while we were talking with her, the guy in the right on this photo simply walked up, pushed open the unlocked door, and was standing outside of this unit, just a couple of feet from us, close enough that we can see the mask that he's wearing is barely covering his face. And unfortunately, this was common, where most of the hospitals and clinics that we visited didn't have the financial resources to be able to purchase equipment that they needed, or even to buy basic supplies like masks that can be used to help protect both their healthcare workers and visitors to the hospital. Tuberculosis now ranks along HIV as a leading cause of death due to an infectious disease, and it's a top 10 killer worldwide. So how and why is a curable disease so deadly? There are a lot of reasons for this, many of which I saw firsthand on my trip to Guatemala. Like in the previous slide, there are inadequate healthcare facilities and resources. There's also social stigma surrounding the disease that I think is fueled by a lack of knowledge and education about TB. And then there are issues of the improper use or the abuse of medications, and improper or inadequate ways to perform diagnosis and perform surveillance of those that have been infected. And this can lead to increasing rates of drug resistance. But tuberculosis doesn't just affect areas such as these. In fact, TB cases are increasing here in the United States. And I think that this is shown by all the different reports across the country by the US media that have occurred over the past year or two. Even here close to home with reports in Ohio. When I got back from my trip to Guatemala, I visited the health center here on campus to get my tuberculosis skin test. I'm required to get this test once a year for my program and because of the research I do. I was turned away that day that I went to the health center because I didn't have any symptoms. I couldn't provide a written letter from my mentor stating the exact date of my exposure, and I wasn't due up for 7 months for this annual test. So I had to leave and wait the 7 months and then come back to get tested. And I think that this is an example of the reactive attitude that we have towards the disease that underscores the need for us to change our approaches to research, diagnosis, and treatment. So let me back up and explain to you how the disease is transmitted. The disease tuberculosis, or TB, is caused by the infectious bacterium Mycobacterium tuberculosis, or MTB. And it's thought that MTB is transmitted primarily by inhalation of liquid droplets containing the bacteria. So the bacteria is inhaled and travels and it is deposited into the deepest portion of the lung, shown here, called the alveolus. So in the majority of people that are exposed to MTB, they will develop an initial infection, but they're able to maintain this infection in a form of latency. That's like a form of dormant infection. But in those that do have progression to active disease, most cases of TB are pulmonary disease, that is, disease that occurs within the lung. But TB can spread throughout the body and cause disease in different regions of the body in extrapulmonary TB cases. So you can think of MTB infection as existing along this complex spectrum, where, as I mentioned in the previous slide, most individuals are able to maintain this infection in a form of latency. And it's just the small tip of this triangle that represents those that have active disease. And it's these individuals that have symptoms, but more importantly, they're capable of transmitting to others, where every one case represents an individual that can infect about 10 to 15 new people. But because I mentioned that most people have latent infection, and they are usually asymptomatic, it makes their diagnosis difficult. And while they aren't capable of transmitting to others, to add to the complexity, there is about a 10% reactivation risk in their lifetime. This is the chance that they have progression to active disease. But this varies based on the individual and is due to different risk factors, things like age of the individual, their HIV infection status, if they're in contact with others that are infected, medications they're taking, and different comorbidities. Things like if they have diabetes or if they smoke and use alcohol. So I think because of the complexity in infection, the way that it progresses differently in the human population, it really makes researching TB as well as diagnosing and treating it very challenging. So the traditional research approach in the TB field starts off with preparing the bacteria, MTB, that's grown on an agar plate. And this agar plate serves as a rich source of nutrients for the bacteria to grow and thrive. So the bacteria is grown up in the lab setting. It's then prepared for an infection study in a model host organism, something like a mouse. And the mouse is coming from a genetically identical background. It's inbred for research purposes, and it doesn't serve as a natural host for MTB infection. These infection studies are usually carried out for longer periods of time, and that allows us researchers to be able to assess the survival of the organism over time, and also to study changes in the host immune response over time. But because of the complexity in TB in humans, and it being a human disease, I think that this traditional research approach has a couple of limitations. The two main being the MTB environment that's studied, and the second being this focus on long-term survival. Because we know that early events that are occurring during infection are really critical and help to dictate later-term events. So how does our work in the Torrelles lab address some of these research limitations? I'll start with the MTB environment that's studied. So in our lab, we focus on studying the first environment that MTB encounters when it's inhaled and deposited into the alveolar space. And that's shown here as a blown-up image of this alveolar space, which is lined with this rich lung mucosal fluid, which you'll see as the light pink color in this photo. The lung mucosal fluid, also known as alveolar lining fluid, abbreviated ALF, is full of different host factors, some which we know are important for regulatory functions, like aiding in breathing, and others that have been shown to play a role in host immune defense. So when MTB is inhaled and deposited into the alveolar space, it becomes bathed within ALF, coming into contact with these different host factors. And it's this early interaction that we study in our lab. So our lab is previously published showing that when MTB is exposed to human ALF, and this is ALF that we've obtained from healthy human donors, that there are hydrolytic enzymes present in ALF that are active and capable of acting to clip and cleave away molecules from the MTB cell wall surface. So how did these factors present in ALF modify the MTB surface? We see that when MTB is exposed to ALF, that there are significant reductions on the cell wall surface of the bacterium of these virulence factors. And these virulence factors are molecules that MTB expresses on its cell wall surface. And they've been shown to be recognized by host cells. They can drive invasion into these cells and establish infection. So we see that when MTB is exposed to human ALF, and I'll note that this occurs in just as little as 15 minutes interaction, that we see significant decreases of these two major virulence factors, about 70% and 35% on the MTB cell wall surface. So we know that host factors present in ALF can modify the MTB cell wall surface. How does this then impact the interaction between MTB and host cells? This is looking at the amount of bacteria that's taken up during infection by human alveolar epithelial cells. Now, these cells are important because they provide the physical structure to the alveolus. They also communicate with different lung cells in the lung environment, and they've been shown to play an important role in different respiratory infections, including MTB infection. So as you can see here on the x-axis, we've obtained ALFs from 17 different healthy human donors. And we see amongst these samples that there are differences in the factors and the way that these ALFs modify MTB that drives this very heterogeneous response during infection of human alveolar epithelial cells in the amount of bacteria that they're capable of taking up during infection. And now I'd like to focus on how studying these early events are critical to help us to dictate the later term events and how it's important to take a step back from that focus on long-term survival. So this is looking at how the early interaction between MTB and ALF before infection can help to drive differences in bacterial growth rate during infection of human alveolar epithelial cells. And this is over the course of 5 days infection, where we see that we've identified a subset of ALF whose factors modify MTB, driving this high exacerbated growth rate over the course of 5-day infection. So through our work in the lab, by focusing on early interactions that are occurring in the lung environment, we hope that we can shift our focus towards more of a host-driven approach through identifying which factors are important in ALF, how they're important in infection, and understanding the host pathways occurring during MTB infection. And through this, we can get a better understanding of latency, how to maintain latent infection and manipulate it to prevent progression to active disease, because this can prevent the transmission of tuberculosis. TB has been called many things over the years. Recently, I saw in the news, it was referred to as the silent killer and the forgotten plague. But if there's one thing I hope you don't forget from my talk to you today, you've been listening to me now share my work for about 10 to 12 minutes, and tuberculosis has killed 36 people. And while this is a pretty striking number, it does just represent a number. So for me, it was important to be able to take that trip to Guatemala, see tuberculosis firsthand in those communities, and see the people it affects, because now I don't see the number, but I can really see the people that represent that number. Thank you.